Hi, I'm Dr. Mitchell Roslin, and I'm the Chief of Bariatric and Metabolic Surgery at Lenox Hill Hospital in New York and Northern Westchester Hospital in Mount Kisco, New York, and a Professor of Surgery at the Barbara and Donald Zucker School of Medicine at Hofstra Northwell. I've really been very fortunate through bariatric surgery to be able to travel throughout the world and speak about many operations. I've also been very instrumental in the development of the Single Anastomosis Duodenal Switch, an operation that many people know as SADI or SIPS, and speak about what I believe its advantages are. Recently, I gave this talk in several of the state society meetings, and many people asked me to record it and place it online. So I look forward to doing that, as well as getting your feedback, and hope that I'm able to do this in a very informal and simple manner that makes bariatric surgery and the advantages of this procedure more understandable for patients as well as practitioners. To begin, there really is no perfect bariatric procedure. In fact, bariatric surgery is different than every other branch of surgery. Usually we try to remove an abnormal organ or fix an abnormal part. In bariatric surgery, we actually create an abnormality to try to make people less hungry and full faster. As a result, there is no perfect operation. Bands, as shown on the top, were very popular until the last few years, as we realized that by just placing a ring on top of the stomach, we can make it more difficult for people to eat and force them to eat slower. But we really do not mimic the satiety signals or change the digestive hormones that send signals to the brain. Gastric bypass has been one of the most popular procedures and is still a very effective procedure. But in the upcoming slides, I will try to speak about why I think a single anastomosis DS offers certain advantages. Sleeve gastrectomies have become the most popular operation done. The sleeve is very, very effective. It makes the stomach small. But you can imagine if you make a small tubular stomach, that's going to create more resistance, and that greater resistance can result in increased gastroesophageal reflux. The bottom line is there's never going to be a perfect operation, but our operations are very, very effective for creating weight loss and improving overall health, but all will have symptoms. What I want to try to explain is why SADI seems to make sense and fits better with the physiology and the causes of obesity. In order to treat obesity well, it's really, really very important that you understand what the causes of obesity are and what works and what doesn't work. And one of my goals in surgical practice is to try to have our operations align with what we've learned about obesity. For years, we've treated obesity by telling people that they should eat fewer calories and exercise more. The problem is that your caloric intake and your exercise level are linked. They're not independent variables. Additionally, when you eat less, the body becomes a more efficient machine resisting weight loss. So what happens is as you begin to reduce your caloric intake, the body's metabolic rate declines, making it more complicated to lose weight. And when you try to exercise more, you become hungrier and you eat more. As a result, what happens is you see short-term weight loss, but then the body becoming more efficient and the brain trying to tell the body to increase its weight to offset the weight loss. Obesity actually is a breakdown in the thermostat and the central nervous system, basically setting your weight too high. Essentially, the thermostat is set too high and tells your body to increase its fat stores. It's an energy regulation disorder. It's not a disease because people take in too many calories. This is a very, very important determination, and one of the reasons that surgery works. As surgery changes our energy regulation and down regulates the system so that you could be happier at a lower set point. This is a very important point that we'll return to several times in this talk. One of the most important things that doctors can do with bariatric patients is to understand their expectations. Too frequently, patients just explain to us, "I want to improve my health." One of the real truths is that many people who have suffered from severe obesity do not want their weight to be noticed. They want to reach a normal weight, a weight when they walk down the street, people don't view them as being heavy. A lot of times people say, "I'm going to have the bariatric," and it assumes that all bariatric procedures are normal. This really is not true. The most common procedure done today is the vertical sleeve gastrectomy. And as you can see from this graph, if your goal is to reach a normal BMI, which means a BMI of less than 30, that means you're not obese, normal's 25, class 1 obesity being 30, class 3 obesity being 40. If your BMI is more than 45, then only 30% of people are going to reach that level. That doesn't mean they don't lose weight. Our average patient loses 30% of their body weight. But the idea that everybody is going to reach a non-obese rate is not really true. And when your BMI gets to 50, that number goes to 5. This is shown graphically here. For example, with vertical sleeve gastrectomy, most of our patients will lose 30% of their body weight. Sometimes people ask me if they can do better. And of course, it's a bell-shaped curve. So certain patients do better. And what we see is that about 25% of our patients will lose more than 35% of their body weight. What's very, very encouraging about sleeve gastrectomy is that 87% of our patients will lose 20% of body weight. However, for patients that have BMIs that are greater than 50, as I mentioned, only 5% of those patients will get to a non-obese rate. They'll get substantially better. But when they lose this amount of weight, and then there may be some weight regain at the end, many of these patients 5 years later will still be morbidly obese. Interestingly, when we add the intestinal component to a sleeve gastrectomy, as done in Single Anastomosis Duodenal Switch, that weight loss goes up to about 40% of body weight. While that may sound roughly the same, what we're talking about is total body weight. That means that by adding the intestinal conduit, we're going to get approximately a third more weight loss. Additionally, one of the things that we see about the intestinal conduit is that it prevents some return of weight or weight regain. Now again, as I mentioned at the very beginning, there is no perfect bariatric procedure. So when you add the intestinal conduit, you have an increased risk of vitamin deficiencies as well as frequent bowel movements. Additionally, another group of patients or other groups of patients where a more aggressive operation that combines a sleeve gastrectomy, as is done in Single Anastomosis DES, with an intestinal bypass that can benefit from the procedure are patients that have profound metabolic syndrome and severe insulin resistance, such as diabetics that require insulin therapy and have elevated hemoglobin A1Cs despite maximal therapy, as well as patients that have not done well with other procedures such as banding, sleeve gastrectomy, or even gastric bypass. For revisions, I think it's best to understand that conversions work, but doing the same thing again is probably not the best idea. Again, one of our biggest goals has been trying to match our bariatric procedures with our understanding of obesity. When bariatric surgery was developed, many people had the erroneous notion that fats made you fat. That's why we needed a short common channel to make our operations really efficacious, like what we see in the laparoscopic duodenal switch. We now understand that that's not a correct viewpoint, that obesity and the real cause of obesity is an energy regulation being disturbed at the level of the brain, setting the thermostat high. And it's a hormonal disease, and the most important hormone is insulin. And what happens is that patients become insulin resistant as well as have high baseline levels of insulin. Additionally, the body's thermostat, which is supposed to be controlled by leptin, is also broken. So they become insulin resistant and leptin resistant. The bottom line is that fat's not the culprit. If fat's not the culprit, then you don't need a short common channel that only interferes with fat absorption. If fat was the culprit, the drug Ali or Xenical would have been a much more successful pharmaceutical. So let's start putting this all together. Obesity, the real cause of obesity, are elevated insulin levels. And what drives elevated insulin levels is the intake of simple carbohydrates and sugars, as well as foods that stimulate insulin production. And then what happens is you make more insulin and your body becomes relatively resistant, and you have to make more insulin because you don't want to become diabetic. What's really fascinating is that at the beginning of my career, the operation that I performed most frequently was Roux-en-Y gastric bypass. It's still a very, very popular procedure. And in gastric bypass, what we noticed is actually it causes increased glucose variability. We used to believe that that was a good thing, that it caused what was called dumping, and we would tell patients that ate sweets are best served by gastric bypass because what would happen is their sugar would go up and their sugar would abruptly go down. And that would keep them, because of the symptoms when their sugar goes down, from eating sugars. However, I've done a considerable amount of research that shows that that's not true. And the truth of the matter is that the goal of treating obesity is to keep glucose levels stable, to prevent glucose variability. What you see in this diagram is a study that our group did, where we compared all the bariatric operations. This was before the Single Anastomosis DS. And we gave them a glucose challenge. And what we saw is that gastric bypass had the highest glucose variability, and the duodenal switch had the least. The sleeve was somewhat intermediary. We believe that this was a real contradiction, because we want to teach our patients to have stable glucose values so their insulin levels don't rise. And keeping insulin low allows fat to be broken down and fat not to form. As a result, we began to look past the gastric bypass and look at procedures that could do a better job of regulating glucose. So we now have new technology that's actually been mainly used in diabetics called continuous glucose monitoring. And this is a typical patient. This is a male patient that came to see me regarding bariatric surgery, was not on any medications for diabetes. And you can see the glucose curve kind of tells the story of what happens in obesity. What you see is that the elevated or the average glucose increases, but what really increases are the amount of up and down swings called glucose variability. And we can look at that on the bottom graph called standard deviation. So when we compare this to somebody who's not obese, in general what we'll see is a higher mean glucose as well as increased glucose variability. And the reason this occurs is that as weight goes up, patients need to make more insulin to try to control their sugar. As a result, when they eat things that are going to precipitate a higher sugar, it takes them a longer time to clear that level, and they have these peaks and valleys. And again, the most important thing to understand is that obesity is a hormonal disease, and it centers around the hormone insulin. And the treatment for obesity is trying to keep your glucose at a stable level. And the issue that we see with gastric bypass and the advantage of SADS is that gastric bypass shows actually a lot of glucose variability. What you see here is my continuous glucose curve as a 57-year-old male. As I've been treating obesity long enough, I realized that it was really becoming important that I practice what I preach. And when I realized that this is a hormonal disease and not related to calories in and calories out, I changed my diet. Also became extremely active, which I've generally always been. And I think what happens when you're active is that your muscles become more sensitive to insulin. And what you see here is that by controlling diet as well as being very, very active, and you can see the times when I ate, you can see that in turn, compared to the last patient that was a bariatric surgical patient, that my curve is very level. The fluctuations in the glucose that I have are very small. You know, occasionally you see some, but not nearly as many as you saw in the last graph. And this is what we're trying to achieve. And what's very, very interesting is when I look at curves in post-bariatric surgical patients, the single anastomosis DS curve looks a lot like this in a lot of patients as opposed to the gastric bypass curve. So this is a patient that came to see me because she was regaining weight following gastric bypass surgery. Interestingly, her mean glucose is 93 as compared to mine, which is 100. So that's great. That means she's not diabetic. But now let's look further into her curve and let's look at the amount of fluctuation she has. And you can see the signals there when she eats. So as compared to my curve, she has a lot more up and down motions. You know, the sugar goes up, the sugar goes down, and this especially happens at night. So what happens is during the day, she's pretty good, eating the diet that's prescribed. She gets hungry at night, eats something, her sugar goes all the way up, and her sugar plummets. And what do you do when your sugar gets low? You eat again. And you see this cycling, which especially gets worse in the evening levels. So the way she gets to a glucose of 93 is by having a lot of high values and a lot of low values. Therefore, we can't just look at the glucose number. We want to look at the glucose variability or the spikes on the curve. And I believe that these spikes on the curve are why a lot of gastric bypass patients regain weight. So the glucose variability that we assumed would keep them from eating sweets, I actually believe is the cause of weight regain. And if you speak to gastric bypass patients that regain weight, they'll tell you the same history, that they can still eat less, but then they eat something, they get fatigued, and the way they relieve that fatigue is by eating again. And those are the symptoms of low sugar or hypoglycemia. The bottom line is I firmly believe that our bariatric procedures should limit glucose variability. Now, this is a patient that was referred from another area with the most severe form of glucose variability following gastric bypass. Now look at her curves, and you can see it goes all the way up to 300 and down to 40. This is a patient that was actually passing out and disabled following her gastric bypass. And this is a condition called neuroglycopenia. This is not a common complication following gastric bypass, nor should it scare you. However, increased glucose variability is the rule. Severe glucose variability causing these type of symptoms is rare. However, it reiterates my belief that the goal of bariatric surgery is to try to regulate glucose and match the normal physiologic stage as best as possible. And gastric bypass, I believe, is an excellent option when dealing with complications such as a stricture from a sleeve gastrectomy, or for dealing with severe reflux or patients that have Barrett's esophagus. But for primary bariatric procedures, I believe it's best that we pick procedures that limit glucose variability. And I think that the single anastomosis DS is an excellent procedure, especially for patients that have a high BMI, BMIs greater than 45, certainly more than 50, have failed other bariatric procedures or not done as well as they'd like, or patients that are on insulin or other significant medications for metabolic syndrome. We treated the last patient that you saw and her neuroglycopenia. She was passing out. What we did is we put a feeding tube into her bypass stomach and we fed her with a formula, and you could see that we essentially had a flat line glucose curve with no elevations. Once we had this data, we went ahead and reversed her gastric bypass, and her symptoms have completely gone away. But this demonstrates that it was the gastric bypass itself that was giving her the increased glucose variability. In comparison, now let's look at this curve of a patient that had a single anastomosis duodenal switch. This is a patient that was now 6 months postoperatively. Again, you can see the much flatter line, the glucose being in range, and the decreased glucose variability as compared to the gastric bypass curves. In my opinion, this is physiologically what we want and physiologically superior. We want operations that promote the ability to regulate glucose and prevent fluctuations, prevent variability. Because again, when you have increased glucose variability, what happens is you're going to eat more frequently to relieve the hypoglycemia. As a result, I think that this is a much more advantageous way to get positive long-term results. This is data that comes from a study that was performed in Europe that used continuous glucose monitoring comparing the gastric bypass to the traditional Roux-en-Y duodenal switch. On the top graphs, you can see the gastric bypass, and again, you see a lot of these up and down fluctuations. On the bottom line, you see the single anastomosis duodenal, the Roux-en-Y duodenal switch. And again, what we see with preservation of the pylorus in the duodenal switch anatomy, as opposed to gastric bypass, is decreased glucose variability, less glucose fluctuations. And again, I believe that physiologically, this allows patients to become less hungry and have more persistent weight loss. This is data from my good friend Juan Antonio Torres from Spain, who developed the European version of SADI and has worked closely with myself and Daniel Cottam, who have been proponents in the United States, where he compared gastric bypass to single anastomosis DS or SADI and did continuous glucose monitoring. Again, you can see up top the increased fluctuations, and on the bottom, a more level curve, which is exactly what I believe we're after. So here you can see a summary of the results, and what you can see is that the standard deviation, which means the amount of glucose variability, is lower in the single anastomosis DS. The highest level of glucose is lower in the single anastomosis DS, and the lowest value is highest, meaning that again the glucose doesn't go up and down, which is much more physiologic and much less likely to result in increased eating. Well, we spent an awful lot of time talking about glucose regulation variability and the advantage of the single anastomosis DS. But what is this operation? The first thing we do is we create a sleeve gastrectomy, or a tubular stomach, that's bigger than the standalone sleeve. Then, right past the pyloric valve, which means gatekeeper in Latin, we divide the first portion of the duodenum, as you can see here. And then we splice the food so it goes halfway down the intestine. So the intestine is about 6 to 8 meters in patients. We count backwards approximately 3 meters, and then we attach that portion of the small intestine to the portion of the duodenum. As a result, food goes straight to the distal intestine. Why is that important? Again, obesity is a hormonal disease. So food is only following the blue circuit here. When food goes down the blue circuit, it stimulates hormones that tell the body that the patient is full or they have increased satiety. Again, you can see the mechanisms here. We remove the stomach, so ghrelin is reduced, and we stimulate the LNK cells, which make incretins. So what are the results following single anastomosis duodenal switch? Essentially, patients will lose about 40% of their body weight, which corresponds usually to about 20 to 22 BMI units. Stated differently, for patients who have a BMI of 40 to 45, they're very likely to reach a weight that puts them outside the obesity classification. For 45 to 50, that goes up to 80%. And even from 50 to 55 BMIs, our percentages is approximately 50%. Again, when you compare this to sleeve gastrectomy, considerable benefit. Another thing that we see is that the intestinal bypass limits recidivism or weight regain. So if we return to the graph that we saw, which compares the sleeve gastrectomy, what we're going to see with the single anastomosis DS is that for patients that would have inadequate weight loss, whose BMIs are greater than 45, that the single anastomosis DS has a much greater chance to get these patients to a non-obese level. Again, the need for micronutrients and the risk of increased bowel movements are increased. As a result, there is no perfect operation. Besides the group that has increased BMI, another class of patients that I think benefits from using both the stomach and intestine, as is done in single anastomosis, are patients that are diabetic, especially those that are on insulin. Some general rules. If you've just been diabetic recently and are controlled by oral hypoglycemics such as metformin, any weight loss will work. For those that have been on insulin or with severe insulin resistance, the duodenal switch operations such as single anastomosis DS are going to have the best chance of getting you into remission and limiting the amount of medications that you need to take. The risk of utilizing the intestine, especially aggressively, as is done in single anastomosis DS and DS or distal gastric bypass, is the risk of vitamin deficiency, the risk of iron deficiency, the risk of bone hunger, elevated PTH, and protein malnutrition. What you can see is that the nutritional status after 1 year with the single anastomosis DS that we do in the United States, that Dr. Cottom and I have advocated with 3 meters, generally shows acceptable levels of vitamin D, vitamin A, as well as albumin. Again, this is across all patients. It is essential that you take your supplements. Additionally, even though this is a very powerful operation, it is absolutely imperative that you learn about nutrition and learn how to eat appropriate whole foods that are full of vitamins and nutritional parts. There is no substitute for a correct diet. Unfortunately, many people who are obese got that way by eating a lot of empty calories. People with morbid obesity are more likely to be malnourished than supernourished. As a result, supplements, dietary education, and adhering to these recommendations is absolutely essential. To reiterate the point that there is no perfect bariatric procedure, this is all of the complications that took place in the clinical trial for single anastomosis DS that I was principal investigator, again, along with Dr. Cottom. Put into perspective, primary bariatric surgery has become as safe as joint replacement, as safe as gallbladder surgery, and probably safer than colon surgery. But there can still be complications, especially when doing a significant procedure. It is essential that if you're considering having a single anastomosis DS, that you go to a center that is experienced, a surgeon that knows how to do the procedure, as well as one that's surrounded by dietitians that know how to properly educate you about the postoperative diet as well as the adaptive changes that need to take place. There will never be a perfect bariatric procedure, and especially when dealing with high-risk patients, there can always be complications. Again, I think it's important to pick the best procedure the first time, because there's no question that revisions are much more complicated, and there's no more complicated revision than transforming a gastric bypass to another successful procedure. I think this is a very important study. These are the results of that study that Dr. Daniel Cottam and his group put together, along with many of the other proponents of this procedure. Dr. Cottam looked at the anastomotic complications as well as the risk of small bowel obstruction, things like ulcers, things like strictures, and he was able to show that following a single anastomosis DS, or the version that we called SIPS in the United States, which is what we've advocated, done over a 40 to 42 French Bouzy, so it's a sleeve that's slightly bigger than the majority of sleeves done, and a 3-meter intestinal bypass, we saw significantly less leaks, less strictures, less ulcers, and less small bowel obstructions than is seen in gastric bypass or traditional duodenal switch. We think this shows a tremendous advantage to the single anastomosis version. One of the things that people forget is that the risk of bariatric surgery on a young patient exists for the rest of their life. While there'll never be a procedure that doesn't require any revision, being aware of this type of data is absolutely essential for making the correct choice. In summary, as mentioned, bariatric surgery is an imperfect solution for a very significant problem. The practitioners that you see should understand the causes of obesity, understand the impact of high insulin levels, and that it's not all calories in and calories out. I hope that we've demonstrated the advantage of a single anastomosis DS and why I think this will be a future procedure. It's essential that you be presented with all of the options and understand how they treat the real causes of obesity so that you can make the best and proper choice. I believe preserving the pylorus is important, and I believe that the single anastomosis DS has many advantages compared to procedures such as gastric bypass for many patients. If you're interested and you need more information, please visit our website at nycbariatrics.com or call the Lenox Hill Bariatric Program or the Northern Westchester Bariatric Program. We also can be reached at 188-Y-WAIT. I hope that you've enjoyed this presentation, and if you have any questions, please feel free to email.